CVS Part 1 Case Study 14.
A 64-year-old man with chronic heart failure with reduced ejection fraction, here 25%, is followed in the cardiology clinic. He was progressively treated with the ACE inhibitor and had persistently elevated B-type natriuretic peptide levels. His therapy is transitioned from lisinopril to sacubitril or valsartan after 24 hours of washout period. 2 weeks later, he reports symptomatic improvement. Repeat laboratory evaluation shows persistently elevated BNP levels but a marked reduction in the NT-proBNP. Several hours after taking his morning dose, he presents to the emergency department with acute onset of facial flushing, tongue swelling, throat tightness and difficult breathing. On examination, he has lip and tongue edema, hoarseness of voice and inspiratory stridor without urticaria or rash. Which of the following best explains both the biomarker pattern and the patient's acute presentation? Option A. Analytical interference with BNP assay and IgE mediated drug hypersensitivity. Option B. Neprilysin inhibition causing reduced BNP degradation with decreased myocardial wall stress, lowering NT-proBNP combined with bradykinin mediated angioedema due to inadequate ACE inhibitor washout. Option C. Selective suppression of NT-proBNP synthesis with valsartan hypersensitivity reaction. Option D. Progressive heart failure causing discoordinate natriuretic peptide expression and allergic angioedema. Option E. Direct stimulation of BNP production by sacubitril and complement mediated angioedema.
So here in this case, two key pharmacological concepts have been discussed. First concept is this, that when we give ARNI to a patient, that is angiotensin receptor blocker and a neprilysin inhibitor. Neprilysin inhibitor is sacubitril and angiotensin receptor blocker is valsartan in this case. So what a neprilysin inhibitor will do, neprilysin enzyme degrades BNP, which is a natriuretic peptide. And if we give neprilysin inhibitor like sacubitril in this case, then it will lead to less degradation of BNP. So we will get high values of BNP. So a patient in acute decompensated heart failure, chronic heart failure, if given ARNI, will give a falsely high BNP values. So in this case, instead of BNP, we use NT-proBNP for interpreting the hemodynamic status. As we can see that there is resolution of heart failure, so with the resolution of heart failure, hemodynamic improvement, we get lower values of NT-proBNP, which shows that there is resolution of the heart failure gradually. So this is one of the pharmacological concept. And what is the second pharmacological concept? That when we are transitioning a patient from ACE inhibitor to ARNI, like in this case, we are transitioning the patient from lisinopril to sacubitril and valsartan, then what we need to take care of, that the washout period for ACE inhibitor should be allowed for. That is minimum 36 to 48 hours. Only after a proper washout of ACE inhibitor, we can start an ARNI. Because the circulating bradykinin gets degraded by the angiotensin converting enzyme. And in ACE inhibitor, as the angiotensin converting enzyme is inhibited, it will lead to less degradation of bradykinin. So there are very high levels of bradykinin circulating in the blood. Furthermore, when we give an ARNI like sacubitril, that will again lead to less degradation of bradykinin. So we will get a storm of bradykinin in the blood, which will lead to angioedema and which becomes a medical emergency. So this transitioning is very careful and it has to be done in a very careful way. Waiting for the washout period is mandatory. So we have to take care of these two key pharmacological concepts in this case. Now coming to exclusion of the wrong options and selection of the right one.
Option A is analytical interference with BNP assay and IgE mediated drug hypersensitivity.
So there is no analytical interference in the BNP assay. The BNP assay is correctly done, but we are getting falsely high values, and the hypersensitivity is bradykinin mediated, not IgE mediated. There is no urticaria and rash.
Option B, neprilysin inhibition causing reduced BNP degradation with decreased myocardial wall stress, lowering NT-proBNP combined with bradykinin-mediated angioedema due to inadequate ACE inhibitor washout.
This is the correct option.
Option C, selective suppression of the NT-proBNP synthesis with valsartan hypersensitivity reaction.
So there is no selective suppression of NT-proBNP. NT-proBNP is telling about the resolution of the heart failure, and again it is the hypersensitivity reaction is not caused by valsartan because valsartan does not lead generally to hypersensitive reactions.
Option D is progressive heart failure causing discoordinate natriuretic peptide expression and allergic angioedema.
No, this is also not true.
Option E, direct stimulation of BNP production by sacubitril and complement mediated angioedema.
So, and sacubitril leads to decreased degradation of BNP, and thus the BNP values are high. It does not lead to direct stimulation of production of BNP. And again, the angioedema is bradykinin mediated.
Not complement mediated.
Not complement mediated.
Search Edumedex on Instagram and YouTube to start your journey today.